Professor Dr. Hemant Kumar from Pudukkottai, Mahatma Gandhi Medical College and Research Institute. And third, Dex Medical Medicine by Resident Dr. Ishan Arachar from Pune. And our chairperson is today, for today's webinar is Professor Dr. Saroj Bande from Pune. Now I invite our secretary to deliver the welcome address. Over to Dr. Periyasamy, Secretary of ISA Pudukkottai branch.
Thank you, sir. Thank you, sir. Good evening. On behalf of ISA Pudukkottai, I welcome you all for this 49th ISA online webinar program, Pudukkottai Budan. Once again, I welcome you all. This is the history of our ISA Pudukkottai online webinar program. We started this event in the month of March 23rd of 22nd last year. And continuously we are conducting this program for so many weeks, and we ended this program 49th week, and we are having 3 important topics. With this history, the history began, the man is our academic chairman, Dr. ISA Pudukkottai sir. On behalf of ISA Pudukkottai, I would like to thank and invite our academic chairman, Dr. ISA Pudukkottai sir. And I thank our academic chairman for his successfully conducting this program almost 1 year from 2022. And the backbone of this, our ISA Pudukkottai, our president, Dr. Suresh Kumar sir. I invite and welcome our president and thank him for his support giving for this program continuously. And I would like to invite and welcome our treasurer, Dr. David, and others, delegates, those who are attending this program and supporting us from the beginning. And I would like to invite and thank all the participants of this program, 49th program. So we are having 3 important topics today. One is anesthesia for bariatric surgery. Another one is positioning for optimal laryngoscopy. And third one is dexmedetomidine. For these topics and this program, I invite Dr. Saroj Bande as a chairperson to chair this session. Sir is senior consultant, Chem Hospital, Pune, Maharashtra. On behalf of ISA Pudukkottai, I welcome you, sir. Next, we are having 3 important speakers for this program. One is Dr. Rashmi Valimbe, consultant, Chem Hospital and Research Center, Pune, Maharashtra. Madam is going to talk on anesthesia for bariatric surgery. On behalf of ISA Pudukkottai, I welcome you, madam. And next speaker, Dr. Hemant Kumar, professor and head, Mahatma Gandhi Medical College and Research Institute, Pudukkottai. Sir is going to talk on positioning for optimal laryngoscopy. I welcome you, sir. And third speaker, Dr. Ishan Prashkar, resident, Chem Hospital, Pune, Maharashtra. Sir is going to talk on dexmedetomidine. On behalf of ISA Pudukkottai, I would like to invite and welcome you all for this 49th program. Our program is very special because we are agreed by Tamil Nadu Medical Council, and already we registered for that. And we got approval for this conducting this program. At the same time, they are giving credit hours for speakers as well as delegates, those who attend this program. For that, we require your details, email ID, mobile number, attendance, the screenshot of your attendance, name as in Medical Council registration, and payment of 100 rupees to be paid our account, those which is displayed here. And mail the screenshot image of your payment and other details to our email ID isapudukkottai@yahoo.com. This is more important. So today we are going to talk about most important topic, obesity and related surgery. So a small poem about that. Obesity produces calamity in enormity. Every day is struggle if you eat more. Fat deposited in the body without our interest, making things worst. Fat shield the body against pain or pleasure. Joint bear the weight and become sad. Heart pump the blood without any rest, become unrest. So less sugar and less salt and walk each day and day by day. Make lifetime changes carefully. Healthy life will come naturally. With this, I thank you all and thank you for the opportunity. Over to President Dr. Suresh Kumar, sir. Thank you, sir.
Thank you very much, Dr. Periyasamy. Respected Secretary, ISA Pudukkottai Branch, Treasurer, Dr. David, ISA Pudukkottai Branch, our Academic Chairman and Director of Medical Education of Tamil Nadu, Professor Dr. A.L. Meenakshi Sundaram, sir. Respected Chairperson of today's webinar, Dr. Saroj Bande, Madam. Speakers of today's event, Dr. Rashmi, Professor Dr. Hemant Kumar, and Resident Dr. Ishan. The assembled senior anesthesiologists, members of ISA Pudukkottai and other branches of Tamil Nadu and India, practicing anesthesiologists, budding anesthesiologists, residents and postgraduates. A warm welcome from Team Pudukkottai Budan from Pudukkottai. As you all know, we are on a long historical journey, but it was the Pudukkottai Budan has become a national important webinar on every Wednesday because of its practicality. So many topics we have discussed in this forum and so many speakers have participated, and especially residents also participated in all the webinars fully. So this is an innovative program orchestrated, led by our academic chairman. At this juncture, I thank our Professor Dr. A.L. Meenakshi Sundaram, sir, for bringing out this practical program from the folds of ISA Pudukkottai branch given to the anesthesiologist nationwide. And today we have some three important topics. As you all know, obesity is an epidemic disease in the developed and developing nations of this 21st century. And Dr. Rashmi Madam will enlighten us how to manage these patients who have come for bariatric surgeries. The next topic regarding performance of laryngoscopy and what is the optimal position. Many times we will forget it to do so. Even though we are aware of it, we will forget it. So Professor Dr. Hemant Kumar will guide us and give some useful practical tips. We are waiting for that. And last one, the dexmedetomidine, a wonderful drug, come for the anesthesiologist in this 21st century for sedating the patient in our anesthesia OT as well as in critical care settings. And Dr. Ishan will enlighten us. So now I request every member of this, every audience of this webinar to participate fully and engage in useful chat discussions at the end of this session. And once again, I welcome you all from my side, and I hand over the proceedings to Professor Dr. A.L. Meenakshi Sundaram, sir. Over to Dr. A.L., please.
Thank you, Mr. President. Respected President, Secretary, Treasurer, and members of Pudukkottai ISA, distinguished faculty, Dr. Saroj Bande, Dr. Hemant Kumar, Dr. Rashmi, and Dr. Ishan Parashar, and all the distinguished delegates. Good evening to all of you. Even it is amazing to see the ISA Pudukkottai started its journey, this Pudukkottai Budan, on 23/3/22. Today it is 22/2/23. So it is quite coincidental, and we are almost nearing 1 year. We have to finish 3 more. So from 23/3/22 to 22/2/23, we have seen so many enthusiastic faces spread across the country. All the districts, states participated in this, and naturally Maharashtra is having largest number of anesthesiologists. Maharashtra participated to the maximum. So we have covered 49, and I am waiting when the March 15th will come, so that we will complete that 52nd episode. And today we are happy to have our youngest faculty, Dr. Ishan Parashar, who is a resident in KEM Hospital, who is groomed by Dr. Saroj Bande and Dr. Rashmi. So we welcome him, and he is supported by Dr. Rashmi Madam. Actually, Dr. Rashmi is a consultant in KEM Hospital, Pune, and she has dedicated her life for bariatric surgery. It is surprising to see she has anesthetized all complicated cases of bariatric surgery. In fact, myasthenia gravis complicating bariatric surgery, she has anesthetized. Pulmonary hypertension complicating bariatric surgery, she has anesthetized. Another peculiar thing is a dwarf, kyphoscoliosis, restrictive lung disease, she has anesthetized with ultrasound guided central neuraxial blockade. And just because I have seen that, we will arrange a person to deliver a lecture on ultrasound guided CNB because of that. And moreover, after the bariatric surgery in the post-surgical area, in a multimodal analgesia, she has presented a paper on erector spinae block as a complementary in multimodal analgesia. So definitely she has dedicated her life for bariatric surgery, but she used to weigh only 40 kg. See her physique, it is absolutely amazing to see a puny anesthesiologist is anesthetizing a bariatric patient. So we wish him all success, and we are quite happy to have her here. And our next speaker is Dr. Hemant Kumar, known to everyone. Even I have prepared a flyer. I asked his photograph. He has sent his photograph without naming him, because we know he is Dr. Hemant. So I have typed it as Dr. Hemant and I have sent. When it is sent for proof correction, he said, "Sir, I am Hemant Kumar." See, today only I know that he is Hemant Kumar. That is day before yesterday. He is always affectionately known as Hemant everywhere. So not only in Tamil Nadu and Pondicherry, throughout the country, he is a popular person because he is a original researcher. He has dedicated his life for research. He has published some 25 national publications and 18 international publications. So he is a professor and HOD of the prestigious Mahatma Gandhi Medical College, Pondicherry. Even we have many faculties from Mahatma Gandhi Medical College, Pondicherry in our Pudukkottai Budan. And he is interested, originally he is doing a lot of research on laryngoscopy positions. So he was very much willing to deliver a lecture on this, and he is a certified instructor in ACLS courses by the American Heart Association. Moreover, he is international coordinator for all these resuscitation courses. So his interest is wide. Just because he is interested in airway, he is having a lot of interest in CPR also. Then he is working like a machine. So naturally, he is interested in anesthesia machine. So his wide area of interest and his dedication has made him as a highly qualified academic anesthesiologist. And we are happy to have him here. And to match, to cope up with all these people, we wanted to have a best chairperson. So it is none other than Dr. Saroj Bande. She is a senior consultant in KEM Hospital, Pune. She has more than 30 years of experience in anesthetizing high-risk cases. And Madam is having a PDCC postdoctoral certificate courses in neuro and cardiac anesthesiology. And Madam is a top rank holder in BJ Medical College during her MD anesthesiology. She is the first rank holder and she is second in Pune University. So she is the most intelligent, and coincidentally, her husband is also an anesthesiologist. He is having a qualification in general MD as well as anesthesia. So he is MD anesthesiology, MD general medicine. So he has come down to Tanjavur to deliver a lecture in ISA sponsored CME. He has come for my son's marriage at Pudukkottai. So I know his entire family, and now match these two statements. Madam is most intelligent. Bande is also intelligent. So these intelligence got mutually anesthetized and they have become spouse. So that is the best part of it. So madam is a dedicated teacher and he is a much sought after guide for postgraduates. So the idea of me introducing all the four in length, we always will cross before the original session begins. We will cross the delegate strength of 50 routinely by 6:15. Today it is 58 and it is 6:19. So now I hand over the session to Dr. Saroj Bande madam to conduct. So as things stand today, I think the ideal sequence will be patient should be induced with the dexmedetomidine. Then the position should be ideally positioned for a laryngoscopy. Then the patient has to undergo bariatric surgery. So I have given the clue. Discussion will be at the end of all the three. Madam, please take over.
Yeah. Can you hear me? Can you hear me, sir? All of you?
Yes, madam.
Yes, yes.
Okay. Yeah, thank you, sir, for that kind introduction. And at the outset, let me congratulate all your team for consistently carrying out this activity right from the March 2022. And very consistently you have carried out, and you seem to have covered so many topics. I'm sure all the practitioners and postgraduates must be benefiting from this all these talks. And a very nice thing that you are also giving a chance to the postgraduates also to speak in this. They definitely need to contribute like this from the beginning to the growth of our specialty. And with this, I'll request Dr. Ishan to start with his talk. As all of us know, dexmedetomidine has become the keyword for so many things. It has got multiple applications in anesthesiology, critical care. And so we need to know more about this drug, and I'm sure Ishan will definitely increase our knowledge. Share screen. Full screen.
Desktop. Share.
Now, 1 second, just
Use password.
Madam, if there is a problem in share screen option, Dr. Hemant can start. Madam, Saroj, madam,
yeah.
because the share screen option you have to check.
Yeah.
Share
Shall I
screen
start,
is it
sir?
box? Madam,
Yeah.
madam,
Then shall we start with his talk now first?
yeah, it has come. Dexmedetomidine has come.
Yeah.
Next, madam.
It has come, madam.
Yeah, okay. Yeah. Then Ishan can start. Yeah.
That went away, no? One second. Do I go down? No. Marker is there. One second. Marker is not. Marker is not. Okay. Respected teachers and my fellow postgraduates, a very good evening to you all. My name is Dr. Ishan Parashar. I will be discussing dexmedetomidine. So to begin with, dexmedetomidine, it's a highly selective alpha-2 adenoreceptor. Chemically, it is the S enantiomer of medetomidine, which has been used for sedation and analgesia in veterinary medicine for many years. Side has to go. I can't see this.
One second.
Can you take this out? I can't see anything from. Okay. So coming to the aspect of pharmacokinetics, following intravenous administration, dexmedetomidine shows a half-life of 6 minutes and a terminal elimination half-life of approximately 2 hours. It exhibits linear kinetics in the range. Yeah. Show me. Show me. Thanks.
Yeah. Go on.
Yeah. Okay. Apologies everyone for the delay. Very sorry. So coming to the pharmacokinetics part. Yeah. Yeah. So it acts as a relatively selective alpha-2 agonist on membrane-bound G protein coupled alpha-2 adenoreceptors. So 3 subtypes of alpha-2 adenoreceptors have been described in humans, that is alpha-2A, alpha-2B, and alpha-2C. So the alpha-2A adenoreceptors are primarily distribution in the periphery, whereas alpha-2B and 2C are present in the brain and spinal cord. Coming to pharmacokinetics, so following intravenous administration, dexmedetomidine shows a distribution half-life of 6 minutes and a termination elimination half-life of approximately 2 hours. So it exhibits linear kinetics in the range of 0.2 to 0.7 micrograms per kg per hour in IV infusion over a period of 24 hours. It is 94% plasma protein bound and concentration ratio between whole blood and plasma is 0.66%. Context sensitivity half-life, which is important when we are using a drug like dexmedetomidine, which we generally use in the form of infusion. So it can range from 4 minutes after a 10-minute infusion up to 250 minutes after an 8-hour infusion. Oral bioavailability is extremely poor. However, after sublingual and intranasal administration, bioavailability is almost close to 84%. The pharmacokinetics are not influenced in the case of renal impairment. However, the sedative effect may be stronger due to lower degree of plasma protein binding. Coming to metabolism and excretion, it undergoes almost complete biotransformation through direct N-glucuronidation and cytochrome P450 mediated hydroxylation. And all the metabolites are inactive metabolites. And they are excreted 95% in urine and 4% in feces. Only 1% of the drug is excreted unchanged in urine. Dose adjustments may be required in patients with hepatic failure because of lower rate of metabolism. Now coming to systemic effects, first we'll go through cardiovascular system. It evokes a biphasic blood pressure response. So there is an initial hypertensive phase due to alpha-2B activity and subsequent hypotensive phase due to alpha-2A activity. Higher affinity to alpha-2 receptor selectively leads to vagomimetic action on heart and vasodilatation. Now in younger patients who generally have higher vagal tone, bradycardia and sinus arrest has been described. which can be treated with atropine and glycopyrrolate. Now coming to central nervous system, the alpha-2 agonists, they produce their sedative hypnotic effect by action on alpha-2 receptors in the locus coeruleus. So sedative effect, it acts through the endogenous sleep promoting pathway. So it generates natural sleep patterns. Significant yet rousable sedation is observed when plasma concentration is between 0.2 to 0.3 nanogram per milliliter. Unarousable deep sedation is observed when the plasma concentration is more than 1.9 nanogram per milliliter. So the analgesic effect is mediated through stimulation of alpha-2C and alpha-2A receptor in the dorsal horn. It suppresses pain transmission by reducing the release of pro-nociceptor transmitters such as substance P, glutamate, and also by hyperpolarization of the interneurons. In peripheral nerve blocks, it causes prolonged action by hyperpolarization of the unmyelinated C fibers and to a lesser extent of A fibers. So there will be more prolongation of the sensory effect and relatively less prolongation of the motor effect. Studies suggest that it has neuroprotective effect by reducing the level of circulating and brain catecholamines. It also improves perfusion in ischemic penumbra. It reduces the level of glutamate responsible for cellular brain injury, especially in subdural hemorrhage. It modulates spatial working memory, enhances cognitive performance. Coming to respiratory system, it does not suppress respiratory function even at high doses. There is no change in arterial oxygenation pH or the slope in carbon dioxide ventilatory response curve. In spontaneously breathing patient, it may reduce minute ventilation. Coming to endocrine effects, it activates peripheral presynaptic alpha-2 adrenergic receptors, which reduce the release of catecholamines and hence reduce sympathetic response to surgery. Now coming to the clinical applications, our search for an ideal perioperative anesthetic agent and adjuvant has been continuously on, where we want an agent which can be used easily, is easily available, does not suppress airway reflexes, and does not suppress respiration much. At the same time, should have some analgesic benefit. So as of now, there is no drug which covers all the aspects of this, but dexmedetomidine comes pretty close. So to start with, it can be used as a pre-medication as it is a sedative, anxiolytic, analgesic, sympatholytic, and has stable hemodynamics. It decreases oxygen consumption in intraoperative and postoperative period. So the dose for pre-medication is 0.3 to 0.7 micrograms per kg intravenous or 2.5 micrograms per kg intramuscular injection, which should be given ideally 15 minutes prior to the surgery. So dose of 1 microgram per kg intranasal produces a median onset of sedation of 25 minutes and median duration of 85 minutes in healthy children undergoing elective surgery. At higher dose, that is almost 2 microgram per kg, it produces faster onset of sedation, and there is no demonstrable difference in the condition of patient at induction, emergence, or recovery. Intraoperative use, it attenuates hemodynamic stress response to intubation and extubation by sympatholysis. When used intraoperatively in lower concentration, requirement of other anesthetic agent is vastly reduced. Fewer interventions are required for the treatment of tachycardia, and there is also an observed reduction in the incidence of myocardial ischemia. So nowadays it is being increasingly used in cardiac surgeries. It is an effective and safe agent for controlled hypertension mediated by its central and peripheral sympatholytic action. Some studies are also calling it the ideal hypertensive agent. Dexmedetomidine via any route has a prophylactic effect in preventing emergence, agitation, and delirium in children anesthetized with sevoflurane or desflurane. It has been successfully used to treat postoperative shivering. It is also being increasingly used as an adjuvant in local and regional techniques. Because of its highly lipophilic nature, it is rapidly absorbed into cerebrospinal fluid, and it binds to alpha-2 adenoreceptors for spinal cord for its analgesic action. It prolongs the duration of both sensory and motor blockade induced by local anesthetic, irrespective of the route of administration. It can be epidural, caudal, or spinal. Dexmedetomidine 0.5 microgram per kg can be added to lignocaine for intravenous regional anesthesia. So we have increased postoperative analgesia. Then it is also used by an intra-articular route in patients who are undergoing arthroscopic knee surgeries, where it is giving us improved quality and duration of post-operative analgesia. Then coming to ICU sedation, it is indicated for sedation in initially intubated and mechanically ventilated patient in the initial 24 hours. FDA is very clear on that part, where it is indicated for initial 24 hours. Now, it has multiple advantages, like it decreases the requirement of opioids almost by 50% in patients who have to be ventilated post-operatively. And it also causes minimum respiratory depression. Now, coming to procedural sedation, there is an increasing use of it for procedural sedation. So it has been safely used for transesophageal echocardiography, colonoscopy, elective awake fiber optic intubation, awake carotid endarterectomy, shockwave lithotripsy, vitreoretinal surgeries, pediatric patient undergoing tonsillectomy, pediatric MRI, and also adult MRI. So the usual dose of dexmedetomidine for procedural sedation is 1 microgram per kg, which is given over 10 to 15 minutes, followed by infusion of 0.2 microgram per kg per hour. So the onset of action is in less than 5 minutes and peak effect occurs within 15 minutes. Obese patient, because dexmedetomidine doesn't cause any respiratory depression, so it can be successfully utilized in sedating morbidly obese patients, thereby avoiding the respiratory depression, which is generally caused by narcotics. It is also useful as an anesthetic adjuvant in bariatric surgery and sleep apnea patients. Pain and palliative care, this is a relatively new frontier, but it can offer a new perspective in the pharmacotherapy of symptoms of distress in patients who are at the end of their life or suffering from cancer, which is intractable pain, agitation, and delirium. And FDA has approved for its use in these cases. Other uses, it is used in the study of evoked potential in patient undergoing brain tumor, epileptic seizure, foci resection, and cervical spine surgery. It has been used in the treatment of drug withdrawal of narcotics, benzodiazepines, alcohol, and recreational agents. It is effective in preventing ethanol-induced neurodegeneration. It is used in the management of tetanus in ICU. So here I have already discussed this, but here I have saliently mentioned the dose of dexmedetomidine used in various procedures like angiolysis and then intraoperative applications for airway procedures, tumor surgeries, and the benefit it can give us in the recovery period. Now coming to precautions, continuous monitoring is mandatory whenever we are using IV infusion of dexmedetomidine in patients who have pre-existing severe bradycardia or ventricular dysfunction like decompensated congestive cardiac failure. It can be carefully considered or avoided in patients who are receiving digoxin, beta-adrenergic blocker, calcium channel blockers. Caution should also be advised when we are using it in conjunction with drugs who have negative chronotropic effect, especially succinylcholine, pyridostigmine, propofol, and remifentanil. Lastly, coming to adverse effects, the most frequent observed adverse effects include hypotension, bradycardia, dry mouth, and nausea. It may lead to arrhythmias, AV block, cardiac arrest, T-wave inversion, tachycardia, angina pectoris. In some occasion, it may also cause pulmonary edema, bronchospasm, respiratory depression, syncope, neuropathy, paresthesia, paresis, hyperkalemia, lactic acidosis, and hyperglycemia. FDA has currently classified it as a category C drug in pregnancy, so it should be used with extreme caution in pregnancy. Thank you.
Thank you, Ishan. That was really extensive information about dexmedetomidine, and really its applications are increasing day by day. May I now request Dr. Hemant Kumar to to start his talk about the optimal position for the laryngoscopy.
Yes, madam. Is my screen visible, madam? Hello,
Yes, Dr. Hemant, it is seen.
it is seen. Okay. Good evening, everybody. I'm audible, sir? Am I audible, sir?
Audible.
Good evening, everybody. Thanks to the organizers for giving me this wonderful opportunity to give a talk. I also thank Meenakshi Sundaram sir for his kind words. Now today we are going to discuss about positioning for optimal laryngoscopy. Common doubts what we get is whether to keep the pillow for laryngoscopy, the pillow, what size of the pillow to be used.
RPR, please 1 minute. Dr. RPR, please switch off your mic. Dr. RPR. Dr. RPR. Dr. RPR, switch off your mic. Mute yourself.
Shall I continue, sir?
Yes, please proceed.
Now we are going to discuss about, the positioning for optimal laryngoscopy and whatever the doubts which I expressed. Let us see whether my talk clears all those doubts. Coming to the optimal laryngoscopy, optimal glottic view during direct laryngoscopy is a precondition for successful endotracheal intubation. Hope everybody agrees to this. It is dependent on proper positioning of head and neck during direct laryngoscopy. This is what we believe. Of course, this is the most important thing that need to be done. In addition, the anatomy and the biomechanics of the airway also are the most important things for direct laryngoscopy. Now let us see common head and neck positions employed by anesthesiologist. The first thing is head extension position. This is the position which we see where most of the postgraduates, they don't keep the pillow and try to do the laryngoscopy and intubate the patients. And this is also seen whenever we find difficult laryngoscopy with the pillow, we try to remove it. It is nothing but maximum head extension with no flexion of the neck, where the patient is placed supine with no pillow under the head. Now we'll see the next position. Sniffing position. Lower neck is flexed to 35 degrees from the torso and the head is extended to at an atlanto-occipital joint, producing a 15-degree angle between the facial and horizontal plane. Every day by keeping the pillow, everybody presumes that they have put the patient in sniffing position. That's not so. You call it sniffing position only when you achieve 35-degree neck flexion and a facial plane extension of 15 degrees. Next position people employ is head elevated laryngoscopy position or ramped position. This is achieved by elevating the patient's upper body and the head using blankets, such as the line from the sternal notch to the external auditory meatus is at the same horizontal level. This particular position is kept for obese patients. Now we have to look at various theories where this position is to be employed for the routine intubations and laryngoscopy also. Next position is backup position. The backup position is achieved by flexing the patient's torso at the level of the hips using the controls on the operation table. So this is nothing but patient is kept in sniffing position and the back of the table is raised by 20 to 25 degree backup for laryngoscopy and intubation. This is the common position which people do it in emergency room for intubations or in critical care departments where people do the intubations with head up. With regard to the history of optimal position for laryngoscopy, there's a lot of literature available. There are conflicting results. There are landmark studies. And if you look at the literature, the first publication that has come out is in 1913, where Jackson stressed the importance of anterior flexion of the lower cervical spine in addition to more obvious extension at the Atlanta occipital joint. This is the first publication. Here, Jackson told about the, axis alignment theory, nor he has not described the sniffing position. He just told that neck flexion and extension helps for good laryngoscopy. Then after a gap of some years, in 1936, Magill described the sniffing position. There's nothing but sniffing of morning air. Here also he has not described about the angles. In 1944, the Bannister and Macbeth, they described the three-axis alignment theory, which stated that sniffing position lead to alignment of laryngeal, pharyngeal, and oral axis, thus making the line of sight fall directly onto the glottis. After 1944, next position that came into vogue is, 1 minute, there is some issue with the logistics. Okay. Next position, they described about this after elevating the head to the flexion of the neck onto the chest and at an angle of 35 degrees and 15-degree extension at the Atlanta occipital joint. Next study came in 1999, where Adnet et al. He challenged the three-axis alignment theory, saying that in sniffing position, alignment of axis do not happen. Immediately within a year, Adnet's study was criticized by Benimoff, saying that the angle used by the Adnet was only 5-degree neck flexion, and because of that, alignment of axis did not happen. So again, Adnet in 2001, he did MRI of various positions, that is neutral, head lift, extension, and sniffing position. And he has measured the angles. If you look at these angles, this pharyngeal angle and laryngeal axis angle, it has not become zero, nor the mouth axis and the pharyngeal axis or laryngeal axis, or even the line of sight, the angles have not become zero in neutral position. The same thing with regard to head tilt and also extension and sniffing position. In sniffing position, there is little better alignment, but still the angles have not become zero. Now I'll further explain with this diagram as done by the Adnet. This angle is along the hot palate, laryngeal axis along the lower cervical spine, particularly, and upper cervical spine, atlas and axis, and line of sight along the upper incisors and the cricoid. So if you look at these angles, this alpha angle has never become zero, or this delta angle has never become zero, or beta angle has never become zero. So it is very clear now that during sniffing position, 3-axis alignment doesn't happen. This is clearly proved by the ADNET. In 2001, then came the obstacle theory, where Isino explained that this head elevation during sniffing position, it displaces anterior obstacles, that is tongue, epiglottis, and mandible. And head extension displaces the posterior obstacles, upper teeth, and maxilla. This theory is nothing but obstacle theory, which is proposed in 2001. Then came Greenland. In 2010, he proposed two-curve theory, and this particular theory is well accepted right now, and it is published by Australian and New Zealand Association of Anesthesiologists Guideline for Airway Management. What Greenland tells is the airway passage is divided into two curves, primary and secondary curves, and the 3-axis, not the 3-axis alignment theory. So this is primary curve. Is my cursor visible?
Yes, Dr. Hemant, visible.
So this is the primary curve and this is the secondary curve. And this is line of sight. So the point these two curves meet, it happens in the laryngeal vestibule. Now the successful laryngoscopy depends how much distance between this line of sight and the vertex of the primary curve decreases. That is first thing. Second thing is how this primary curve and secondary curve, they both get aligned to the line of sight. This is what proposed by Greenland. I will explain further with this schematic diagrams. As I already told you, this is primary curve, this is secondary curve, and this is line of sight. So when I put proper position, that is sniffing position, 3 axes are not getting aligned, but this primary curve, if you see this vertex, see initially the curve before sniffing position is this dotted line, and after positioning into sniffing position, this solid line. So the distance from the line of sight, so from here to here, so initially it was from here to here, and with sniffing position, this distance from vertex to line of sight has decreased. This is the reason why the sniffing position is giving optimal laryngoscopy, not the 3-axis alignment theory. Now, looking at the various positions about this neutral position, head extension position, or sniffing position, or just keeping the pillow. In all these, if you look at, this is the primary curve, this is the secondary curve. So this is the line of sight, and from the line of sight to the vertex, so this distance is more. By keeping the pillow, the distance has reduced. In extension also, the distance is less, but it is maximum less only in sniffing position. If you compare all these 4 images in different positions, it clearly proves that in sniffing position, the distance from the vertex of the primary curve and the line of sight is less, and that is leading to optimal laryngoscopy. That is the reason why we are able to visualize glottis better. Hope everybody is clear with this. Now, what happens when retinognathia? As I already told you, the primary curve in sniffing position or in normal airway will be here. In retinognathia, the primary curve has shifted to still more back and the distance has increased. Obesity, where there is short thyromental distance. So initial curve without doing any flexion extension or after doing sniffing position is this. But in case of short thyromental distance, the curve is more and the distance from the vertex to the line of sight is more. And this is the reason for difficult laryngoscopy. Now, Greenland et al., he further went on saying that laryngoscopy involves 2 steps, which I already described. That is, keeping in sniffing position and then laryngoscopy and pushing the various structures. Just by keeping this patient in sniffing position, you are decreasing the distance from the primary curve to the line of sight. This only you are doing by doing the sniffing position. But by doing the laryngoscopy, what you are doing, you are pushing the tongue and the submandibular structures. This is again making this primary curve and secondary curve getting depressed and falling onto the line of sight. And this is the reason better way. So this positioning of the head and neck is one aspect, and doing laryngoscopy by pushing the tongue and other mandibular structures such that the primary curve and secondary curve gets aligned to the line of sight, that is leading to the good laryngoscopy. Now, next came this held position or ramp position. This optimal position of laryngoscopy in morbid obese patients is described as ramped position. Colleen and colleagues, they have done extensive studies on this ramped position. They said that ramping in obese patients is nothing but similar to sniffing position in normal weight patients. This is a statement they made. What is this ramping position? Is nothing but horizontal alignment of external auditory meatus to the sternal notch. Now the question is, should we really align external auditory meatus to sternal notch? We will see further studies and further literature. So this is obese patient. So before ramping and after ramping, for ramping they have used various blankets of different sizes such that tragus to the sternal notch, they are in one line. Now the next question is, we are all putting the patients in sniffing position. But are we measuring the angles? The neck flexion should be 35 degrees and extension should be 15 degrees. That we are not doing. That can be done only with protractor and it is not practically feasible. So keeping this in mind, Greenland et al. Further studied this held position by doing serial MRIs. What he did is, he has put a patient in MRI suit with exactly measuring the flexion of 35 degrees and extension of 15 degrees. And he has taken serial cuts. So this A is tragus or external auditory meatus. When he did the serial cut sections until he reaches the bone, it seems this particular tragus exactly corresponds to this B, that is nothing but clivus. When you cut head in vertical position, if you do serial sections, when you go inside, external auditory meatus exactly corresponds to this clivus B. E is the sternal notch. So he has found that when we keep the patient in sniffing position, external auditory meatus, that is the clivus and the sternal notch, are aligned and in straight line. That's what people are using for head elevated laryngoscopy position. So when this position is kept, C is the nasopharynx and D is the glottis. They fall in one line and that leads to optimal position for laryngoscopy. Hope everybody are clear with this. So the main concept is, by aligning the external auditory meatus, that is clivus, to the sternal notch, we are achieving the proper sniffing position. So to conclude, external auditory meatus and sternal notch, they are the markers to help us to say that we have put the patient in sniffing position properly. This can be applied both for non-obese and obese patients. So to achieve this, now for us to keep the pillows and various blankets, sometimes it will be difficult. So what is suggested is use dynamic inflatable headdress such that you inflate dynamically, such that you get the tragus and the sternal notch in one plane, which is not possible with fixed height pillows what we are using right now. Furthermore, people have clearly proved that 25-degree backup position, in addition to sniffing position, it improves, one is line of sight for the intubating anesthesiologist. Second thing is, it seems less force is required to elevate and move the tongue and other tissues out of the line of sight. And this 25-degree backup position also minimizes the need to stoop by the intubating anesthesiologist. So these are the three advantages if we keep patient in backup position in addition to the held position. So my suggestion as per the various literature is optimal position for laryngoscopy is you put the held position with or without 25-degree backup position. This will give proper sniffing position and it will lead to optimal laryngoscopy. Thank you so much.
Thank you, sir. This was really, with illustrations, you really explained the concepts very well. And I would really like to thank you for that. And can we move now to our third last lecture by Dr. Rashmi Valimbe?
So can you stop sharing your?
Yeah, I'm doing it.
Can you see my?
Yes, madam.
Yeah, I have slightly modified the topic, not only for bariatric, but any patient coming, any obese patient coming for surgery, we can use the same similar anesthesia plan. So coming up, obesity is defined as an abnormal or excessive fat accumulation that presents a risk to health. It is a chronic and progressive disease resulting from multiple environmental and genetic factors. Pre-COVID, ICMR had declared that the prevalence of obesity is somewhere around 16% to 36% in India. But post-COVID has tremendously increased, and some studies nowadays quote that it is even more than 40%. So what are the prerequisites for bariatric or obese patients coming to our OT? So you have to prepare the hospital and the OT for a bariatric patient. You have to do a pre-operative evaluation in advance. That is at least 1 week prior to surgery. We have to optimize or prehabilitate the patient before surgery. The OT personnel should be trained in handling obese patients. The anesthesiologist handling the patient should be trained in handling obese patients, and there should be availability of ultrasound, because in obese patients you cannot see any landmarks. So it's best give any blocks or any regional done is best done under ultrasound guidance. So this is the general classification of obesity according to the BMI of the patient. Now, if obesity doesn't come alone, it comes hand in hand with something known as metabolic syndrome, which constitutes 5 factors, that is waist circumference, serum triglycerides more than 150, HDL cholesterol less than 14 men and less than 15 women, systolic blood pressure of more than 130 millimeters of mercury, and diastolic blood pressure of more than 85 millimeters of mercury. Then fasting serum glucose of more than 110 milligrams per deciliter, or on treatment of diabetes. So if any somebody is
Whosoever is not a speaker, please mute yourself. Please mute yourself. Pallavi, please mute yourself.
Dr. Pallavi, please mute yourself.
So if any,
Yeah.
so can I resume?
Then we can proceed.
So if any three of these 5 factors are present, then it constitutes metabolic syndrome. So what are the indications for bariatric surgery? So any BMI, any patient whose BMI is more than 37.5 without any other comorbidities, or a patient in whom BMI is more than 32.5 with comorbidities like diabetes, hypertension, or metabolic syndrome. Then if there are documented multiple failed attempts of non-surgical weight loss, if there are no other medical contraindications, and there is absence of uncontrolled psychiatric condition, because if the patient has uncontrolled psychiatric conditions, then it becomes becomes impossible for explaining to the patient what he may achieve or what he may undergo. So the bariatric surgeries come mainly under 2 types. One is restrictive and one is malabsorptive. So initially it started as a gastric balloon. Then they came to a gastric band. Then we come across laparoscopic sleeve gastrectomy or Roux-en-Y bypass surgery or mini gastric bypass. And lastly, there's something called as duodenal switch. So in advanced PSC, we see the patient at least 1 week prior to the surgery. We take down his personal details, we measure the patient. Then we ask the patient about history of any associated disorders. Then we do the airway assessment. We ask the patient about all the other histories like allergies, medications, any substance abuse. If the patient is on regular CPAP or BiPAP use at home. Patient may have multiple associated disorders. The commonest is systemic hypertension. We should measure the blood pressure with an adequate size blood pressure cuff, because most of the times these patients, when they go to any OPD, their blood pressures are never measured because the cuffs are most of the times normal size, which are inadequate for the patient. So most of the BP cuffs are not fitting to the patient's arm, or the patient may have conical arms and the BP cuff may just not fit properly and the BP measurement may not be correct. So we have to measure the blood pressure of the patient with a adequately sized blood pressure cuff. Then the patient may have pulmonary hypertension, which comes with obstructive sleep apnea. The patient may be in right or left heart failure. The patient may be having ischemic heart disease. In respiratory system, most of the patients have obstructive sleep apnea. The patient may be having restrictive airway disease because the excess fat acts as weight on the patient's chest and it decreases the respiratory movements as such. The patient may be having GERD or hiatus hernia. Patient may be having diabetes, hypothyroidism. Patient may be having multiple psychological issues like depression, because there is a lot of body shaming. So most of the morbidly obese patients come with depression. Then coming to obstructive sleep apnea, which is the most important thing, which most of the obese patients more than a BMI of 35 have some amount. So what is so it's a partial or complete collapse of upper airway caused by relaxation of muscles controlling the soft palate and tongue. So persons may experience apneic episodes, hypopneas, and flow limitation. Apnea is a cessation of airflow for more than 10 seconds. Hypopnea is decrease in airflow of at least 50%, with a decrease in oxygen saturation of at least 4% from baseline. And flow limitation is narrowing of upper airway and an indication of an impending upper airway closure. So what happens in obstructive sleep apnea? The patient sleeps, whereas the person who's sleeping with the patient remains awake for the whole night. So what happens is when the patient sleeps, the airway, the tone of the upper airway muscles decreases, and there is tongue fall. So there is a obstruction of there's a closure of upper airway, and then the airflow cessation happens, and after some time the saturation starts dropping. Now at a certain critical level, the patient wakes up because of the decreasing saturation, and then the patient starts breathing again. When the patient starts breathing again, the saturation again comes back to normal. Then again patient falls asleep. So this cycle goes on happening multiple times during the sleep. So most of the times the patient does not sleep properly. His sleep is disturbed, and so he is sleepy throughout the day. So what happens in sleep studies, in sleep labs, they count the apneic and hypopneic episodes, and there's something called as the apnea-hypopnea index. So if the AHI is within 0 to 5, then it is normal. If it's between 5 to 15, there is mild sleep apnea. If it's 15 to 30, then it's moderate sleep apnea. And if the AHI is more than 30, then the patient may be having severe sleep apnea. So these are the various symptoms of obstructive sleep apnea, like there are early morning headaches, daytime sleepiness, poor concentration, irritability. Patients keep on falling during routine activities, multiple visits to bathroom during nights. The sleep is restless. There may be choking or gasping for air during sleep, or witness pauses. The relative or the person who sleeps with the patient may observe that there is pause in the breathing in that patient at night, and there is loud persistent snoring. So I have come across a patient who who had stopped going to office because he had to travel for 1 hour, and he used to fall asleep during driving. So he had started working from home because to avoid any accidents while traveling. So how do we assess sleep apnea? There's a scoring system called as Stop Bang. S stands for snoring, T stands for daytime tiredness, O stands for observed apneic spells by an observer, P stands for hypertension, B stands for BMI more than 35, A stands for age more than 50, N stands for neck circumference more than 40 centimeters, and G stands for gender, because OSA is more common in males than females. So if the score is less than 3, then the patient has mild sleep apnea. If the score is between 3 to 5, it is moderate sleep apnea. And if the score is more than 5, it's the patient has severe sleep apnea. So this is a good bedside evaluation test for sleep apnea. So in these patients, we do all the needed investigations like hemogram. The patient may be having nutritional anemia, or the patient is having severe sleep apnea, then his hemoglobin levels may be higher than normal. We should do the patient's renal function test, liver function test, because most of the patients have something called as non-steatotic hepatitis, non-alcoholic steatotic hepatitis. So, and it may even proceed to cirrhosis of liver. So the liver function test should be done. Then serum electrolyte level should be done, because most of the patients are diabetic. The patient should, we should do the coagulation profile of the patient. A blood sugar level or HbA1c should be done, because most of the patients are either pre-diabetic or overtly diabetic or on treatment with for diabetes. Then many patients may be hypothyroid. ECG should be clearly done to rule out any IHD or any other heart problems. A 2D echo should be done. Most of the times a 2D echo, the window is poor, so the cardiologist will say the poor echo window, and the 2D echo also may not be reliable. Then pulmonary function test should be done, which most of the time show a restrictive pattern of airway disease. If the patient has obstructive sleep apnea, or the BMI is more than 40, 45, then we should get a ABG done to know the baseline carbon dioxide levels and the bicarb, partial pressure of carbon dioxide and bicarb levels of the patient. And a venous Doppler should be done to rule out any deep venous thrombosis, because these patients are very prone to DVT and pulmonary embolism. So how do we optimize a patient? For respiratory system, we should start the patient on chest physiotherapy, incentive spirometry. The most important thing is cessation of smoking. Patient should be given bronchodilators if we think that the patient has some amount of obstructive or asthmatic symptoms. We should start the patient on steam inhalation. If the patient is a severe sleep apnea, then we can start the patient on CPAP or BiPAP at home, and motivate the patient for doing all this respiratory prehabilitation. We should treat any other illnesses or disorders the patient may have, like hypertension, coronary artery disease, diabetes, hypothyroidism, and any other problems. All these patients are ASA grade 2 or 3. If the patient's BMI is more than 30, the patient becomes ASA grade 2, and more than 40 BMI, patient becomes ASA grade 3. The patient should be adequately explained the seriousness of his condition and about the post-op need for ventilation or ICU stay if the patient if we encounter any problem during the surgery. Most of the patients are under the idea that they are going for only this cosmetic surgery. But this is not cosmetic surgery. It is for the improvement of the metabolic condition of the patient. That should be explained to the patient, and they should be explained that they come under high risk because they are not ready to accept that they are at high risk for anesthesia most of the times. What are our anesthesia goals? We should always prefer normotensive balanced anesthesia and no awareness. Patient should be completely awake and coherent post-operatively. There should be no residual neuromuscular blockade, and patient should be pain-free. What are the surgical considerations? Now, for bariatric surgeries, you always go for GA. But if the patient is coming for some other surgery, and if you are contemplating to give regional anesthesia, you should ascertain first, can the patient lie flat? Because many sleep apneic patients cannot lie flat. So we have to give GA because patient cannot lie flat after spinal. So how do you pre-medicate the patient? We use antiemetics like ondansetron. We use gastric acid prophylaxis. Most of the patients have GERD. It is better that we use proton pump inhibitors preoperatively. We can give bronchodilator nebulization. If the patient is on antihypertensives, then we should continue beta blockers. But if the patient is on angiotensin receptor blocking agents, then I think you should omit them for that day, because they cause extensive non-responding severe hypotension intraoperatively. Then if the all patients should receive deep venous thrombosis prophylaxis. If the patient is a diabetic, then we should omit oral hypoglycemic agents or shift the patient to insulin prior to surgery, and we should give insulin according to the blood sugar levels, and we should go a little low on insulin. Other routine medications, if the patient is taking like any antidepressants or hypothyroid or thyroxine, then we should continue. If the patient is smoker or asthmatics, then we can give steroids preoperatively. You should prepare the OT. The OT table should be such that it can carry the weight of the patient. We should have 2 good IV lines, at least 20 gauge each. A difficult airway cart should always be present in the OT. The patient should be made to lie in a ramp position for induction, so that his tragus and xiphisternum come at the same level. All emergency drugs and equipment should be kept ready. Anesthesia workstation should have a pressure controlled mode. So we cannot just go and do a bariatric surgery or a patient or an obese patient in a operating room where we only have a basic boils and we are just ventilating with a Bain circuit. It is a total no-no for that patient, for such type of patient. The patient should receive TED stockings preoperatively, and we should use calf compression device inside the operation theater. A forced air warmer should be used for keeping the patient normothermic. So this is the airway cart. We keep a bougie, supraglottic airway devices, mask, nasopharyngeal airway, oral airways, Magil forceps, adequate size tube, sticking, and if the patient has a beard, then we keep a roller gauze for tying the tube. So what all monitoring we use? We use all the routine monitors, pulse oximetry, non-invasive blood pressure, ECG, FiO2, end-tidal CO2 is a must because we are doing laparoscopic surgery. Anesthesia gas monitoring if available. Temperature monitoring is a must. If we have a anesthesia depth monitor, then please use it. If we have a neuromuscular monitor, then please we should use it. Invasive monitoring per se is reserved only for patients in whom who are more super obese and in whom we cannot fit a BP cuff at all, or patients are severe OSA in whom we need to do a multiple arterial blood gas analysis, or patient who are having severe pulmonary arterial hypertension in whom also we might need to have a repeated blood gas analysis. And if the patient has ISD and then we might need intraoperatively, and surgery involving compartmental fluid shifts. A central venous cannulation is per se not advised. It should be done only if you cannot get any other IV access for the patient, because all these invasive monitoring make the patient immobile, and we want a mobile patient post-operatively to prevent DVT. So if the patient's arm is such that the BP cuff is not, any size BP cuff is not fitting properly, then we can use a normal BP cuff on his forearm. We can take a baseline BP level pre-operatively and then maintain the BP level at similar within 20% of the pre-operatively BP range. using a forearm cuff. So there are different weights we come across in obese patients. One is the total body weight, that is the actual weight of the patient. The second thing is the ideal body weight. So this is usually calculated by Broca's index, that is in males height in centimeters minus 100 and in females height in centimeters minus 105. Then there's something called as lean body weight, that is patient's weight minus a fat mass, and there's something called as adjusted body weight. So this considers the increase in in the patient's weight over the lean body weight. So it is for lean body weight plus 40% of the excess body weight of the patient. So these are some formulae to calculate the lean body weight and ideal body weight of the patients. So in obese patients, what we see is as the patient's weight increases, the lean body weight up to some extent, the lean body weight increases, but after a certain amount, the lean body weight comes to plateau, whereas whatever increase in total body weight is there, that is because of the increase in the adipose or fat tissue weight. So coming to dosing of the drug, so most of the drugs are given according to the lean body weight of the patient, except for propofol, which is given according to the adjusted body weight, and scoline, which is given according to the total body weight of the patient. So basic principles, whatever I narrated, like use regional anesthesia wherever possible, use opioid sparing anesthesia. Induction is always done in RAM position, low volume, high rate ventilation with PEEP. Then normotensive anesthesia, DVT prophylaxis is a must and multimodal, and extubation always in propped up position. So what do you mean by opioid sparing? We can give paracetamol, magnesium sulfate, and lignocaine combination pre-operatively 15 minutes before inducing the patient. So this helps in preventing intubation reflexes also. We can use NSAIDs like diclofenac for supplementing analgesia. Induction is done with a combination of fentanyl, ketamine in analgesic doses only, and propofol till the patient sleeps. And we can use regional anesthesia wherever possible in addition to general anesthesia. So induction is always done in RAM position. Ketamine co-induction is preferred. We should pre-oxygenate the patient for at least 3 minutes so that the FRC gets saturated with oxygen and the safe apnea time increases. Nasal airways should always be kept ready because in these patients, more than intubation, ventilation is the most difficult part. And supraglottic airway devices should be always at hand if we can't ventilate the patient using a mask. And before giving a muscle relaxant, always confirm ventilation. Also, contradictory to this same statement, if we after giving a muscle relaxant, then the ventilation most of the times becomes easier than without a muscle relaxant. So you should weigh the consequences and both the things and give relaxant accordingly. So this is a RAM position. So that this is the same patient when supine and same patient in a RAM position. So definitely we can see that in a RAM position, the laryngoscopy becomes easier. Also in supine position, manipulating the laryngoscope handle becomes difficult. So introducing the handle inside the patient's oral cavity becomes difficult. So yeah, as such, laryngoscopy becomes difficult in a total supine position. If we don't have a ramp, then we can construct a ramp by using multiple blankets and sheets or pillows. So these are the different techniques to open the upper airway. So this is a head lift, chin lift, head tilt, chin lift, and jaw thrust. And most of the times, an obese patient, we cannot ventilate with one hand technique, and we have to have a two-hand technique for mask ventilation. Also, beware of patients with beards and chubby cheeks and fat below the chin. If the patient has beards and if it's not on not because of some religious grounds, please ask the patient to shave off before the surgery. We should look forward to, we should look about the difficult airway predictors like large pad of fat below the chin, beard, neck, restricted neck extension in diabetic patients, mandibular problems like prognathia, macrognathia, missing or loose teeth, and neck circumference more than 40 centimeters. This definitely makes laryngoscopy and intubation difficult. So intubation, in all these obese patients, there's a reduced safe apnea time. So if we use apneic oxygenation by during laryngoscopy by using nasal prongs or something like Thrive, then it is always advisable. Then if the patient has difficult intubation, if we suspect difficult intubation, we can use choline, but because of the fasciculations, choline may further decrease the safe apnea time. So again, we have to weigh the pros and cons of using succinyl choline. Tube size is ideally according to the ideal body weight. Larger BMI often reduces tracheal diameter slightly, so we can use a normal or slightly smaller tube. Ventilation is always controlled, even if for short procedures. Never anesthetize a obese patient on mask ventilation or spontaneous ventilation. We prefer a low tidal volume ventilation according to the ideal body weight of the patient. And if the patient goes into CO2 retention, then we can increase the respiratory rate. We should always keep a positive end expiratory pressure of 5 to 7 centimeters of water and maintain peak airway pressures less than 35 centimeters of water. The IE ratio is usually 1:2.5 or more. Head up position should be maintained throughout so that our respiration is aided. We should always use recruitment maneuvers. That is, when during mask ventilation, we should use CPAP, or then we should actively do recruitment after intubation. So this can be done either manually, or you can use a staircase recruitment maneuver. So for manual method, we can increase the PEEP of up to about 30 to 40 centimeters of water and give 5 to 6 vital capacity breaths using this PEEP, and then decrease the PEEP to about 5 to 7 centimeters of water. Or staircase recruitment, we stepwise increase the PEEP for up to about 15 centimeters of water over 2 to 5 minutes, and then again reduce the PEEP to 5 to 7 centimeters of water for the surgery, and maintain the patient in a head up position throughout. So we maintain the patient on oxygen air inhalation agent if we are using inhalational analgesia, or if we are using total intravenous, then we can use propofol. Inhalation agents, we prefer sevoflurane or desflurane because of their physical properties. Then dexmedetomidine can be used for analgesia and to supplement anesthesia. Then the neuromuscular blocking agents preferred are etracurium or cisatracurium because they are more cisatracurium is more cardiostable. So in most of these obese patients after induction, there may be a fall in blood pressure, so and which may be exaggerated by the histamine releasing properties of atracurium. So cisatracurium is a better drug, and the neuromuscular blockade should always be reversed at the end of surgery. So we can actually either use sevoflurane or desflurane, but with desflurane, the patient becomes awake earlier because of its low oil gas partition coefficient. So it does not get deposited in the fat compartment of the body, and so patient comes out of desflurane faster. So it is a preferred agent. For positioning, all these patients have to be tied to the table because for bariatric surgeries, most of the times the surgeon prefers a steep head-up position. We should look for any bony, we should protect the bony prominences of the patient. We should protect the spine of the patient. We should check the position. After tying the patient, we should check the position and see that the patient is not mobile on the operating table, because they have a shifted center of gravity and the patients may suddenly slip off the table. Analgesia is multimodal. Low dose opioids can be used, supplemented by dexmedetomidine at an infusion rate of around 0.2 to 0.8 micrograms per kg per hour. The NSAIDs can be used with paracetamol, magnesium sulfate, IV lignocaine, local anesthetic infiltration at port site, or truncal blocks like erector spinae block or tab block can be used. Regional anesthesia should be given only UHG guided, because in obese patients, no landmarks are seen. If you want to use erector spinae block, most of the times you cannot even palpate the spinous process in the spine. So it's always better to use regional anesthesia under ultrasonography guidance. They require longer needles. Imaging is most of the times difficult, so you require an experienced anesthesiologist for giving these blocks. So this is a picture of tab block. This is not in an obese patient, so you can clearly see the muscles and the needle. So fat is a mobile organ. So for better visualization, you need help and you should ask somebody to push the fat away from the probe. In the first image, when the fat is not pushed, you can hardly make out any structures. Whereas in the second image, when you push the fat to one side, then you can at least see the muscular layers of the abdomen using the probe. This is a picture of the erectus spinae block. So in lateral, you can give the block after inducing the patient or preoperatively. Preoperatively, you should avoid because the block is painful and the patient may not be cooperative. So after induction, you can turn the patient if possible and give a erectus spinae block in lateral position. So these are other blocks if required, but they should also be given under USG guidance. This is USG of spine. So if you want to use neuromuscular blockade. You have to go, you should give lots of fluids, or you should keep the patient adequately hydrated. You can go even up to 10 to 15 ml per kg of a balanced crystalloid solution. And post-operatively also, you should start oral sips of water within 4 hours. We should give multimodal DVT prophylaxis like good hydration, thromboembolo, deterrent stockings, sequential compression device to be used intraoperatively as well as postoperatively. Early mobilizing the patient. In our setup, we mobilize a bariatric patient within 2 hours of surgery. And also pharmacological DVT prophylaxis by using low molecular weight heparin when needed. Extubation, you should always reverse the patient before awakening. You should always extubate the patient in a propped up position. Patient should be wide awake. Return, the airway reflexes should be normal, and patient should be generating a good tidal volume. Keep difficult airway cart ready. Keep a nasopharyngeal airway ready, or you better before extubation you insert a nasopharyngeal airway and then only extubate the patient. Post-operatively, the patient should be nursed in a 45 degrees propped up position. Oxygen therapy should be continued if till the patient mobilizes. Patient may be given normal saline nebulization if required or bronchodilators. A sequential compression device pump should be continued during the post-operative period. IV fluid should be given 100 to 150 ml per hour as in a balanced crystalloid solution. And the patient should be mobilized as early as possible. Analgesic should be given round the clock. No opioids or sedatives like tramadol, midazolam should be given in the post-operative period, as these patients are prone to go for CO2 narcosis and type 2 respiratory failure. Sips of water should be started after 4 hours. Antiemetics and proton pump inhibitors should be given round the clock. If the patient is diabetic, blood sugar monitoring should be done. Encourage the patient to walk every hour post-operatively, and do not restrict the patient with urinary catheters, infusions, and any other devices and invasive lines. What all complications you might see? One is respiratory failure, which is type 2 respiratory failure associated with CO2 retention. And any other surgical problems, it is very difficult to assess. So anticipate surgical problems. If the patient is complaining of excessive shoulder pain, or patient is having unexplained tachycardia, then you should have a high index of suspicion, call the surgeon and go for imaging techniques, or direct go for laparoscopy if needed, because we had one patient who started bleeding and she couldn't fit in the CT scan machine. So we had to go directly for re-laparoscopy in that patient. Again, rhabdomyolysis is a known complication. It occurs if the patient has hypotension, intraop, immobility, dehydration, or the surgery is prolonged. So it is treated with fluid resuscitation, diuretics, and urinary alkalination. If you have emergency surgeries in an obese patient, again, it's preferable to have an experienced team in the OT. Minimize operative time, have high index of suspicions for complications, and have good imaging facilities. If the patient coming to you has had a previous bariatric surgery, then always remember, if the patient has undergone a sleeve gastrectomy, he or she may be a high-risk patient for regurgitation. So go for rapid sequence induction. The patient may be having multiple vitamin deficiencies, because in a mini gastric bypass, it's a mostly malabsorptive surgery. So they may come with multiple vitamin deficiencies. then the patient may have covert comorbid conditions like previous to the bariatric surgery, the patient may be diabetic, but his sugar may be controlled after the surgery. But in stressful conditions, again, he may revert to a diabetic condition. So you should keep that in mind, that the patient may have covert comorbid conditions for which you need to investigate the patient. Trials tube insertions should be done with care. No forceful insertions should be done. Again, endoscopies, if done, should be done only by experienced personnel, because you may perforate the stomach. Because in a sleeve, it is a high pressure system, so you may easily perforate the sleeve. And the patient may have anastomotic site, ulcers or stenosis or even fistula. Thank you, everyone. That's all from my side.
Thank you, Rashmi, for that nice talk. I think you cleared most of the queries that everyone had, but still I can see some questions in the chat. But before we go to that, I would just like to ask Dr. Hemant Kumar. Are you there, Dr. Hemant Kumar?
Yes, sir. Yes, madam.
Yeah. I just wanted to ask you, many times in bariatric patients, especially, we see that the mask ventilation is difficult, but intubation may or may not be that difficult. So as per your illustrations, what do you think is the cause for that?
I mean, again, it is a question of fatty tissue. I mean, and how the primary curve, I have put up an image.
Okay.
Between the vertex of the primary curve and the line of sight. It gets altered based on the submandibular tissues, and also with regard to the, what do you call, our tongue size and hot palate and neck position. All those things are going to matter.
Yeah, I think, and again, the thyromental and the neck, even neck circumference also, maybe I think that also might be an important factor.
They matter, yes.
So that will usually make our job difficult, I think.
Yes, yes.
And then there are questions for Rashmi.
Madam,
Yes.
Even I want to supplement my views. See,
Yes.
most of the time the mask ventilation is difficult because we take it light. And most of the times laryngoscopy is easy because we are very serious with that.
Possible.
The moment when
Very
we
much
intubate, so you adjust the position, you are keeping a ram position, head up, tilt, so many things. But in mask ventilation, routinely in the neutral position we are doing. Nobody is adjusting the position of the patient. That may be the reason, because of the hidden anxiety within the anesthesiologist. Thank you.
Actually, sir, even in a ramp position, the mask ventilation is usually difficult, but intubation is not that difficult.
That's what. Whenever is there into, madam, routinely we lose the patient in spinal anesthesia if he is posted for ingrowing toenail. But cardiac surgery and major surgery, we are on toes. No cardiac surgery patient dies in the post-operative period.
Although we
but
say
only
that no
spinal
surgery
anesthesia patients die. It is because of the seriousness of the anesthesiologist.
Yeah, possible. Yeah. I just wanted to also add some points to Rashmi's presentation. Pre-operative assessment of the 2D echo, as she said, the window might be small and there might be a restriction. But what again now they are advocating is stress echo with transesophageal. So that can be done in the patients in whom it is indicated, like. And the other thing is preoperative ABG she mentioned, but this preoperative ABG should be kept in mind during the postoperative period also, because especially when the patient is in postoperative, suppose if the patient's preoperative oxygen saturation is not so high, the nursing staff might do this, that if the saturation goes below 90%, they will put oxygen. And there have been incidences where some patients have been lost because of this, because the patients then lost their drive for respiration. And then when you come back after some time and the patient is no more, this has happened. I came across such case reports. That's why especially the patients with more stop bank criteria and with deranged ABG also, we have to keep the baseline values in our mind when you go to the postoperative period also.
Even
And
patient's baseline saturation should be
saturation and
recorded
even
and
bicarb,
defined.
bicarb
So
also.
that
Yeah.
post-operatively, we should instruct the nursing people that the post-op oxygen saturation should not exceed pre-operative oxygen saturation too much.
Yes, that should,
And-
that has to be instructed very
And
well
not
to the
to give
nursing
oxygen
staff. Yeah.
unnecessarily.
Yeah. And the other thing was there are some longer, like we get nasopharyngeal airways from 2-3 companies at our place, but try to prefer the longer, the nasopharyngeal airways which are longer in length in these patients, because they are the ones which are going to help you. And the other thing is that this recruitment maneuvers which Rashmi described, they're supposed to be, the duration is supposed to last for 7 seconds by watch. So that I think it was not there on the slide, so I just added. And recently I came across a series of these bariatric surgeries which were done, 100 cases are reported, which are done with spinal epidural, only with spinal epidural. So these are some of the variations I think which are probably coming up. And the justification that is given is that in the midline, the fat is not so much. And so you can go in for the epidural and spinal. And definitely this obviates the need for the opioids because it's a very strong form of regional anesthesia that you are giving. And the other thing is about nitrous. I think she does not use nitrous at all. But there are many people who ask whether nitrous can be used. And for simple sleeve gastrectomies, what they say is it can be used. But the other procedures, nitrous is strictly, it cannot be used, the other laparoscopic procedures. So that was the other thing. And so there are
For
some,
not using nitrous, because most of the patients don't tolerate nitrous oxide because they desaturate a lot if you use
Yeah.
nitrous oxide.
if that
So
is the
it's
issue, then
better to use
yeah.
air oxygen
Yeah.
rather than using nitrous. Otherwise, there is
Yeah.
no other
Yeah.
issue for using that. And secondly, if the patient has pulmonary hypertension, then also we should avoid using nitrous.
Yes, correct. And the prehabilitation, like she said, we have to see the patients preoperatively a week before, but I would go a little further and I would say we have to see the patient ideally some weeks to months before, because this CPAP treatment, and I think they themselves have published a study about it, that the preoperative CPAP or BiPAP, it can reduce the pulmonary hypertension of the patient, and the patient can be much better optimized to undergo the
I
surgery
say
and
a week
anesthesia.
before, because if we tell the surgeon that I want to see the patient a week before at least, then we at least see the patient before admission. So if we think that a patient requires optimization or CPAP, then we can further tell the surgeon, no, we cannot give this patient anesthesia within a week. And we have to optimize it. We have come across patients who we have optimized in hospital. We have admitted the patient for 15 days in the hospital, and because it was not possible for them to go home and start with CPAP, BiPAP. So we have optimized the patient for 15 days in the hospital, and then we have operated the patient.
Okay, yeah, that's
So
good.
at least 1 week prior we should see.
Yeah, but
If
this
not more.
rehabilitation can go on for
Yeah,
weeks
it
to
can
months.
months
We must
also.
remember that. There's a question from Muthu Kumar Rajgopalan to Rashmi, I believe. What mode of ventilation is best? PCV, VCV, or PCVG?
We can use any mode of ventilation. That there's nothing like what is best or what is not best. The mean airway pressure should be maintained less than 35 centimeters of water. That is more important.
Yeah, we have to mostly use the lung protective ventilation, and don't forget the recruitment maneuvers. That is more important.
Maneuvers are the most
Okay.
important.
Yeah. Then the other question is from RPR. Paracetamol plus magnesium plus lignocaine, one single IV bolus, and how long this will give analgesia?
This we can give only one preoperative bolus. Most of Indian patients are magnesium deficient. So single bolus of magnesium does not increase magnesium levels to cause problems intraoperatively. We should give this as a one single bolus over about 15 to 20 minutes preoperatively, around 15 minutes before induction, so that it decreases the intubation reflexes also. And magnesium also helps as a bronchodilator. It also has a cardiac stabilizing effect. So as it is, it's a very helpful drug in patients who have cardiac problems.
Okay.
As such.
Then there is a question from Muthu Kumar Rajgopalan. How to maintain driving pressure in obese patients for laparoscopic surgeries? I think he means intra-abdominal pressure. Isn't that true? Is Dr. Muthukumar there? Can you explain? I suppose it is intra-abdominal pressure during laparoscopic surgeries. Isn't it? I don't know. Maybe I'll get the explanation in the chat. Okay. What analgesics you advise, Dr. Rashmi? This is from Bharati Mohan S.
We usually keep the patient round the clock on paracetamol, diclofenac. If the patient does not have any renal conditions, we keep the patient on round the clock diclofenac and paracetamol only. But we supplement with erector spinae block or tab block intraoperative. So, and we usually add dexamethasone to the block so that the effect of the block remains for at least 18 to 20 hours. And the main pain of laparoscopy usually is for first 24 hours. Later on, the pain is not that severe. So if we add dexamethasone, the block's action lasts for at least 18 to 20 hours, and then the diclofenac paracetamol round the clock are sufficient to take care of the pain.
Okay. So again, there's a question from Bharati Mohan S. When do we start Clexane in morbidly obese? Before surgery, during surgery, or after surgery?
What we do is we give one shot of Clexane 12 hours prior to surgery. And then we don't give Clexane at all. If your patient is high risk for DVT or if the patient is known IHD, then you can repeat Clexane 12 hours after surgery also. But if your patient is mobilizing properly, is adequately hydrated, then most of the times you don't require Clexane post-operative.
Okay. And also, I think the dose of enoxaparin and
That's
all,
not
it can be according to the
ideal
weight
body
of the
It's according to the
according
ideal
to
body
the-
weight,
yeah.
not according to the total body weight.
total body weight. Okay. And the other thing, are there any other questions? This driving pressure, I think nobody has explained, isn't it? Yeah. Okay. The other thing I think we must remember is if the patient is preoperatively on CPAP or BiPAP, it's a good idea to tell that patient to get his own
machine.
device to the hospital so that he is also more familiar with that device and more comfortable with that. So
And
that will,
post-operatively,
yeah.
we can continue
Post-operatively, we
CPAP
can
or
give.
BiPAP.
Yeah, we
Many
can
surgeons
continue.
say that if they have done a sleeve, then don't give CPAP. But actually, CPAP has not shown any problems in even after sleeve surgeries.
Yeah. Okay. So,
And many patients who have severe sleep apnea cannot just lie down supine. They even while sleeping, they don't sleep supine normally at home also. At home also, they take 2-3 pillows. Many people, we had a patient who once went to bathroom. She could not sleep for a long time. She went to bathroom and then slept in the commode and then had a fall in the bathroom because she slept off in sitting position. So there are many such patients, and obstructive sleep apnea is not that uncommon.
okay. Okay. So I think that's all from
That's all
our
from our
side.
side.
Can I hand over the meeting to Dr. Meenakshi Sundaram, sir?
Yeah. Thank you, madam. We are very happy that you have finished on time. That is somewhat excellent. You have finished on time, and everyone was precisely to their point. So we are very happy, and I wish all the faculty to have a heightened glory. Dr. Rashmi, in addition, weight and glory. So in future, we will see that happening. Now I hand over the session to our president, Dr. Suresh Kumar. Sir.
Thank you, sir. Thank you very much. We had a wonderful sessions. 3 speakers have talked extensively. The presentations were very good. Before concluding our session, I just thank our chairperson, Dr. Saroj Bande, for being with us today and being with us, navigating the session wonderfully. Thank you, madam. I thank all the speakers, Dr. Rashmi madam, Dr. Hemant Kumar, and Dr. Ishan. Everybody, I thank you very much for making this session a wonderful.
1 minute,
thank-
sir, Dr. Suresh Kumar, sir. The former president, former national president Venkatagiri is on the line.
Oh,
So let him have a few words. Yeah.
No. I am in line since the beginning. I was just hearing. Nice talks. No. We will meet personally next week in this weekend in Tirunelveli.
Fine.
thank you, sir. Thank you, sir. Thank you, Venkatagiri, sir, for joining us. Every
1
session.
minute, Dr. President, sir. Dr. Santa Parthiban wants to say something.
Yeah.
Madam, your face is not seen. Adjust the camera. Ah, that's right. Madam, enough.
Sir, I want to know what do you mean by inflatable headrest, Dr. Hemant Kumar, sir?
So Hemant here, madam.
Yes,
I
sir.
think recently it has come out with some like balloon type where automatically the gas will be pumped in such that the height of the pillow will be adjusted and ramping will happen, and the correct sniffing position and external auditory meatus to sternal notch will be aligned. It is available online, madam.
Okay, thank you, sir. Thank you. Very nice. Now, obesity is.
Over to President.
Yes, sir.
Thank you, madam. Thank you, Hemant Kumar, sir. I thank our academic chairman for making this session a very useful session. I thank our office bearers, Dr. Periyaswamy, Secretary of our association, and Dr. David, Treasurer of the association, members, and other delegates who have joined this program, and you made this session a memorable one. I thank the Akrula people for making this program feasible, and A1 Logistics for good technical support. Until we meet in another next week in Pudukkottai Bidan, I once again thank everybody from our team Pudukkottai Bidan. Thank you very much. Thank you,
ma'am.
Thank you.
Thank you, Venkatagiri sir. Thank you, Hemant.
Thank you, sir.
Madam, Saroj madam, Rashmi madam.
Thank you, sir, for the opportunity. Yeah, thanks for the opportunity, sir.
Only 3 more to go. We are waiting with the bated breath.
Yeah, I can see that. Yeah.
Thank you, madam. We will leave.
Really, you've been very perseverant. I can see that.
Thank you, madam.
Thank you.
A1 Logics, you can end the meeting.
Okay.